you know, when we talk about saving limbs and saving lives, this is a young gentleman whose case is very dear to all of us here at Jaws Podiatry. For the subscribers that did see the previous video, we basically, you know, he had a mummified gangrenous great toe. This was about 6-7 weeks. I mean, it started way back when, and then I did send him to a dear friend of mine, an endovascular surgeon, who maximized his vascular perfusion to his foot. So no blood, no healing. So before we decided to do anything, I sent him to my dear friend, the plumber, and he was able to do whatever was necessary to make sure that there was enough blood supply to reach the foot. At that point, the toe was already gangrenous. It was dry, so we knew that it was just a matter of time before it continued to mummify, shrivel, and the body would basically just say no more, and then just either drop it or, you know, we would, you know, amputate the toe. The first video that we uploaded on this young gentleman was the actual amputation, which we did here in the office. Once we did that, the patient went to the hospital and they performed a partial ray resection. Okay, excuse me. So here in our office, it was only the tip. This is all mummified. So we basically just removed it, and then we had more bone, right? All of this. We had the proximal phalanx, this bone was still there, and then obviously the metatarsal. Okay. This is obviously the left, but it was basically the same thing. So that's exactly what we did. We removed this bone and a large portion of this bone. So it's been a couple of weeks since the surgery, and what we're going to go ahead and do today is remove the sutures. And, you know, this is a really important day for a lot of reasons, because we can already see that the wound has dehisced. That's the term that we use, which is basically just open up on its own. There's a lot of reasons why this happens, right? So we'll just start from here. But Dr. Wagner, if everything was sutured perfect, then why would it open up? Right? This young gentleman is how old now?
89.
89 years old. Or 89 years young. And there are so many other contributory factors of why this incision would not heal in its entirety. Like maybe like a patient like a patient like Sebastian, right? Someone that's young, otherwise healthy, or myself, but so what we're essentially doing today is, again, just removing the sutures, because I want to see what's going on underneath. Sometimes these sutures, they get stuck. Underneath all of this dry skin. Gotta loosen them up a little bit like that. It's dry blood.
Feels like something running.
I'm sorry?
Feels like something running.
Running?
I'm moving.
I'm listening. I'm listening to you. You want to say anything? Okay, so ladies and gentlemen, this is what I mean, okay? So I'm just going to remove this here, and then we'll focus on the rest. Okay, this one there is a little loose. Remember, the patient has kept the area clean, covered, and dry during the past several weeks. Am I correct?
Mm-hmm.
So now, let's see what we got. So this is all dry skin. In these cases where you have a patient who's 89 years young, history of vascular disease, diabetes, this is all expected. And what I'm doing is this is all callous, dry tissue, you see? And that really gives us a better idea in respect to the healing capabilities at this point. Really carefully just kind of work it like that. I think this was the end of the incision, was right here. Not sure how, but that looks absolutely beautiful. For a second, I thought the incision even was open, and if you look in there, it's closed. It's all closed. Let's move this way. I know already that this area is definitely open already, you see? But let's try to move. Let's try to move a little bit closer this way. Very carefully, right? Just again, like I said, just removing the overlying callous tissue. Being very gentle. I don't really care how incisions like these heal, as long as they heal. This is about salvage. This is not about aesthetics. You okay there, bud? You okay?
No problem.
Okay, me too. I always love when this day comes around because it really gives us a better idea. Go ahead and debrief this here. See there?
Does it hurt?
Does it hurt?
A little bit.
A little bit? I apologize.
Well, what can you do?
We're all done there. So definitely the good news, the probe to bone. Exam, let's see here. La 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 la. Everything's negative. No probing to bone. So that will definitely heal. Again, this we're not gonna force anything here. This is closed. This looks really, really great. And then a little bit there, but all in all, I'm very content with the progress here. Now, let's go to the other side. And by the way, if anyone is wondering, we lengthened the Achilles tendon here to make sure that he can bring his toes up to his nose. So when he walks, he doesn't put a lot of pressure here. If not, this area will break down. Again, we lengthen the Achilles tendon so he can do this. Move your toes up. More. There you no, don't bend the knee. Beautiful. Super. Okay, like that. You see? So that was the purpose of this procedure, to make sure that we can achieve this. So when he starts to walk, he can actually bring his toes and clear the ground. That way he won't develop an ulcer here. Or have this area break down. Let's come around. This is where I'm still a little. Let's move your foot this way.
I can't move it.
Okay, that's okay.
Move your leg. Your whole leg. No, you can't move your leg like this. You can't do your leg like this.
Huh?
You can't do your leg like that. Yeah.
Excellent. Okay, so this is, it was expected. He had what we call an eschar. Some people pronounce it differently. This is all fibrin tissue. Okay. And my concern and we'll just take a little bit here of this gooey, again, fibrin, yellow, avascular tissue. What am I looking for? I'm looking for blood. That's exactly what I'm looking for. And there it is. Well, at least a little bit. We're gonna have to really put a full core press on this little defect here. Okay.
That's the side that hurts.
I'm sorry. My concern, and now I'm going to talk out loud in front of the family. Okay?
Oh,
Sorry about that.
that hurts.
Are we still friends?
No.
Okay, let's move back here a second. Okay, so
Oh,
you're a good man.
oh boy, I don't know.
You're a gentleman and a scholar.
Oh,
He's not patient though. Anyway.
We're living in that area. No one is patient. So, my concern here is his healing capabilities on this side now. Everything over here looks really good. The bone, specifically the fifth metatarsal.
no.
Okay, where's my bone model?
Right there behind you.
Oh, there it is. So my concern is this bone is right there.
So I can block some of the blood from getting there.
Well, my only concern is that if we and we will I have some ideas in mind to try to expedite the closure of this side. We need to definitely go ahead and implement that like ASAP.
So you can do that.
Okay, so well, we're gonna go ahead and do. Okay, just follow me on this one, Sebastian. So our goal right now, this is gonna heal. It looks great. I'm not worried. I'm now concerned about this. My only concern is bone infection. Where? There. That's my only concern. And if there's bone infection there, it means that the only way to eradicate the bone infection is how? Exactly. So I have, again, like I said before, I have some things in mind that we can try to see if we can gain some traction here. And it's going to either happen quickly or not. I know you understand everything.
I can't hear too good. I got hearing aids.
I know that you understand everything that we have discussed today.
I don't. Because I didn't hear too much.
I will explain it to you again, okay? Like always, www.jospediatry.com, Instagram, Dr. Toad, Jam Jospediatry, Facebook, and